We are truly thankful to Dr. Harsh Kumar, who's the Director of Glaucoma Services of Center for Sight Group of Hospitals. Again, an amazing glaucomatologist and has held many senior posts in the GSI. Thank you so much, Dr. Harsh Kumar, for being with us and a big support for us. And he's going to be talking on preferred practice guidelines, systemic workup in glaucoma, the when, what, and how. On to you.
Thank you, Chitra, for having me in this fast-forward mode. So if you wanted to check who will going to stumble
This is
first.
all the time Partha gave.
Yes,
so.
yes, I know that. So whether systemic workup is required or not, actually eye is the only way where you can look into the heart and into your soul and into your body. So yes, you must. There's no question that you have to look into it. And simple things, just high BP, I think most of us have already got it. So it will invariably relate to your so it will lead definitely to high intraocular pressure, high, and we know that CRVOs can be produced. So obviously we have to look at the high BP, but we are more worried about hypotension. As more and more of our patients come with NTG, we realize that the ocular perfusion has to be good. If it is not good, then we are in trouble, and nocturnal BP fall of more than 10% is definitely associated with both advanced functional visual field deficits and greater structural damage. So what we are now routinely doing in most of our patients are 24-hour BP monitoring, and invariably we add on the Holter monitoring with it, especially in patients who are on antihypertensives, because these are the people who will get night dips and then they'll get unexplained progression. So please be very careful, get a 24-hour BP monitoring done, and then if the BP is dropping below 70, you have to speak to the cardiologist. You cannot tell the patient to speak to the cardiologist, they will not listen to them. And the cardio doesn't understand what is going on. Most of our patients are one-eyed. If they get into this kind of a trouble, we are in trouble, so we have to reduce their antihypertensives. Another important thing which has come up is the obstructive sleep apnea. So who are these people? These are people who will get at least 1.7 times greater chances of developing glaucoma over a 5-hour period. And these people are usually fat with a double chin, and they usually snore loudly. So these are the things that you ask for. And then they get into incomplete sleep, depression, fatigue, morning headaches. And there are so many other things besides glaucoma that can be associated here, which I really didn't know about. And so basically what is happening is hypoxia, hypercapnia, reduction of ocular perfusion, going into glaucomatous optic atrophy. But the biggest thing is that if you do a sleep study and you put them on CPAP machines, they can be alleviated. So really this is something which is a game changer. Obviously we do all look for diabetes, migraine, thyroid, because we know they are associated in some ways. But the newer things which are coming up are the CSF pressure. Unfortunately, we don't have non-invasive techniques still to detect that, but we do know that if the CSF pressure is low, there could be along the lamina cribrosa, there could be a gradient which can really get us into trouble. And very, very important for all NTG patients to get into a complete systemic workup. Again, perfusion pressures, you have to check for arrhythmias, hyperviscosity, hyperlipidemias. You have to check for the history of major injuries and surgeries where blood may have been lost. MRIs are important because sometimes you land up with pituitary tumors giving a picture just like that. If you have increased episcleral venous pressure, it could be related to venous obstruction, AV anomalies. So scleritis, thyroid, orbital tumors, superior vena cava syndrome, keratocaverous fistulas, and the list goes on. And yes, it could be idiopathic as well. So obviously you do a MRI brain and orbit, and really it reveals so many secrets to you, especially in systemic diseases. Sturge-Weber syndrome, you can see a tram track, and MR angiography can help you diagnose AV malformations, which can actually help you to save a life later. Again, MRI brain and orbit will give you a tumor as well. The neovascular glaucomas, we usually always said that it was diabetic and CRVOs which used to get them, but more and more often I think you people will be seeing that too. We are getting ocular ischemic syndromes where these two diseases are not present. And then we have to really do a systemic workup to check out the carotid occlusive disease, because one can do an endarterectomy and really get away with it. So there are so many other things that there is a huge list, and there's no way in 6 minutes I'm going to finish that. So all these things need to be checked up properly, and all these tests need to be done. Again, uveitic glaucoma, the important thing over here is that you have to do all these tests, HLA, B27, B51, ANA, RA factors. The one thing only I want to emphasize is that at least 3 patients in the recent past I have seen being treated at premier institutions going on for months and months, and the uveitis is not getting treated. They are on steroids and antimetabolites. Nobody bothered for a very, very detailed history. We did a PET scan and they blew up like a Christmas tree. For God's sake, in cases of uveitis which are not being treated, if you do a PET scan and you catch them early, it may be life-saving. Again, infective disease like sarcoid, tuberculosis, syphilis, etc., we all know. In Axenfeld Rieger's, please concern the CVS abnormalities and other skeletal abnormalities must be looked at. In aniridia, serial renal ultrasound can be life-saving if you detect the Wilms tumor in time. So in conclusion, not only it gives you a direction to manage if you do a good systemic workup, but please and definitely it can be life-saving. Thank you very much.
Thank you so much, Dr. Harsh. You covered so much in the 6 minutes.